It's the night we've all been waiting for, prom night. Nothing, and I mean nothing, can ruin this night, right? Except, ooh, why does everything suddenly feel so wet? Well, I guess this is as good a time as any to discuss pre-labor rupture of membranes and preterm pre-labor rupture of membranes, or better known as Prom and Pprom. Pre-labor rupture of membranes, or Prom, is when the amniotic membranes rupture before labor starts, as in before the mom-to-be has begun experiencing contractions that lead to cervical change. When someone uses the term Prom, they're also implying that the pregnancy is at term, as in 37 weeks gestational age or higher. But a more specific way to refer to this is term Prom. This is in contrast to preterm pre-labor rupture of membranes, or Pprom, which refers to rupture of membranes before 37 weeks gestational age. We're going to symbolize Pprom with this pre-prom staging area. You know, the place where everyone gets ready, the bathroom. In the past, Prom and Pprom stood for premature rupture of membranes and preterm premature rupture of membranes. But as you can imagine, this got pretty confusing, so the words were changed, but thankfully the acronyms weren't. Finally, there's pre-viable Pprom, which is rupture of membranes early in the pregnancy at or around the threshold for fetal viability. This is roughly less than 24 weeks gestational age, though this cutoff is often up for debate. We're going to symbolize pre-viable Pprom with this private door. It's locked 24/7 to remind you that the usual cutoff is around 24 weeks gestational age. This must be where mom and dad are hiding the ETOH. Term Prom happens in about 8% of all pregnancies. While the exact cause is unknown, it's thought that at term, the membranes begin to weaken, probably in anticipation of delivery. The mechanism of preterm Prom is what many researchers have been trying to get at, because this is something we'd like to be able to prevent. Like with term Prom, the exact mechanism is unknown. However, many risk factors for Pprom have been identified, which we'll go over later in the patient presentation. From now up until we talk about treatment, we're going to go over the risks of and the risk factors for those with Pprom, because, well, Prom isn't nearly as big of a deal since the pregnancy is at term and she can deliver. We'll discuss management of both Prom and Pprom, but for these next couple sections, it's all about preterm pre-labor rupture of membranes. The largest maternal risk factor of Pprom is preterm labor and delivery, represented on this worried mother's apron as a prematurely hatched chick. Another risk of Pprom is intraamniotic infection, which is an infection of the amniotic membranes that can lead to both maternal and neonatal sepsis. This happens because the previously sterile intrauterine environment is now open and exposed. We'll represent this maternal risk with this string of bacterial lanterns next to the worried mother. Lastly, there's placental abruption, symbolized by the smoke detector abrupting off of the ceiling. The fetus can be compromised as well, either via the aforementioned infection, which can lead to sepsis, or a prolapsed cord, which can lead to fetal asphyxiation and death. Notice how those bacteria lanterns are close to mom and baby? And hey, those red and blue ribbons sure remind me of an umbilical cord. Pprom carries with it the risk of complications of prematurity, as most of these pregnancies will be delivered preterm. These include respiratory distress syndrome, symbolized with our recurring symbol, the shark, necrotizing enterocolitis, represented by this black skull shirt over the baby's belly, intraventricular hemorrhage, which is more common with lower gestational ages and is represented by this red bow on the baby's head, and finally, pulmonary hypoplasia and skeletal deformities, also known as the Potter sequence, which is a consequence of oligohydramnios starting at a very young gestational age, usually before 24 weeks. We'll represent this with the squished Potter bear, a recurring symbol from Sketchy Peds. Now let's move on to our patient presentation. The typical chief complaint of those with Prom and Pprom is a sudden gush of fluid or a continuous leakage of fluid from the vagina, but you can remember it as water leaking from this faucet. In terms of demographics, those with a low BMI, specifically a BMI less than 19, are at higher risk of Pprom and preterm delivery. It's been hypothesized that this is due to maternal malnutrition. Those of low socioeconomic status have also been found to be at higher risk of Pprom and preterm delivery. As you can imagine, the precise contributing factors within this association are numerous and multifactorial. However, Pprom affects many pregnancies, so don't dismiss patients who don't fall within these demographics who complain of leakage of fluid. That chief complaint should always make you consider rupture of membranes. As you've already seen with our description of the typical patient demographics, many of the risk factors for Pprom are the same as the risk factors for preterm delivery. Both a history of Pprom and a history of preterm delivery increase the risk for Pprom in the current pregnancy. We'll symbolize these risk factors with mom and dad's old prom photo and an old photo of a prematurely hatched chick. Infection remains the most known risk factor for Pprom, specifically vaginal, cervical, and intraamniotic infections. That's why there's another string of bacteria lanterns by these old photos. Another known risk factor for Pprom is antepartum vaginal bleeding, specifically placental abruption. With both infections and antepartum bleeding, the infection itself or the blood is thought to contribute to a microenvironment that's conducive to membrane rupture. Though, again, the exact mechanism is unknown. Ugh! Cerclage, which is a stitch placed in the cervix to keep it closed for those diagnosed with cervical insufficiency, and amniocentesis are two procedures performed prior to 24 weeks gestational age that increase the risk of previable Pprom. With both of these, the risk is very low, however, it is still present. We'll symbolize cerclage with this big stitch at the bottom of the uterus backpack, and amniocentesis with this syringe in this bowl of apple juice? Must be some molecular gastronomy thing? Kids these days. At my prom, we just had beer. Water. Cigarette smoking is known to vastly increase the risk for Pprom, yet another reason to not smoke in pregnancy. We've put up this no smoking sign in the bathroom to really drive this point home. Don't smoke. In terms of vitals, check to see if mom has a fever. As you'll see in a bit, whether or not mom is showing signs of an infection will drastically alter your management plan. This girl was curling her hair when some of it caught on fire. That'll help you remember to consider fever. The most important part of the physical exam when it comes to assessing those who have reported a large gush of fluid or continuous leakage of fluid from the vagina is the sterile speculum exam. If her membranes are ruptured, you'll see pooling of liquid in the posterior vaginal fornix, and you may see liquid coming straight out of the cervical os, either on her own or when she valsalvas, like with a cough. That's why we have this girl holding a speculum dripping with water. Was she trying to curl her hair with that thing? No wonder it didn't work out. Another sign of an infection in mom is fundal tenderness, so make sure to check for it on your abdominal exam. It's exactly what it sounds like. When you press down on the fundus of the uterus, it's, tender. Just like this girl's stomach is going to be because her frenemy is pushing her out of the way just to get a look in the mirror. Vanity. In terms of the standard workup of preterm prelabor rupture of membranes, you should test for all the possible lower genital tract infectious etiologies that could have caused it. This includes swabs for gonorrhea and chlamydia, represented by this gondola and clam painting above this girl holding a makeup swab, Group B strep, represented by our recurring GBS baby, and a wet mount to test for bacterial vaginosis, candida, and trichomonas. You should also get a urinalysis and urine culture to test for a urinary tract infection. There's a bucket of yellow liquid in the bathroom next to a petri dish. Don't know what pre-prom ritual this is, but I don't think I want to. As a part of the standard workup for these patients, you must assess fetal well-being, usually with a non-stress test. On a tracing, if she's ruptured, you may see variable decelerations, which are due to umbilical cord compression. We've symbolized this with a variable deceleration pattern skirt that's cinched tight with this red and blue umbilical cord-looking belt. Based on this girl's outfit, we smell a future doctor on our hands. The reason cord compression happens is because significant leakage of fluid removes the amniotic fluid cushioning that normally keeps the cord from being compressed. If mom has an infection, you may also see fetal tachycardia on the fetal heart tracing. We'll represent this with our recurring symbol for tachycardia, a raised heart watch. This girl is telling her friends to hurry up. They're gonna be late. The big question in diagnosing Prom or Pprom is whether or not the membranes are actually ruptured. There are a number of tests that are used in conjunction to determine whether or not this is the case. Most require a sterile speculum exam for either inspection or collection. Once you've placed your speculum, check to see if there's pooling of fluid in the posterior vaginal fornix. If you don't, or if you want to be really sure where the fluid is coming from, have your patient cough, and you may see fluid come directly out of the os, in which case this is diagnostic of ruptured membranes. We'll remind you of this with this girl who is, coughing to get her friends to hurry up. The limo's almost here. These girls are not quite ready yet. We're going to stick around here for a little longer because we still want to really confirm that the patient's bag of water broke. So you're going to take a swab of whatever fluid you find and use it for the next two tests we'll discuss, the Ferning test and the nitrazine test. For the Ferning test, you're going to take your swab of liquid, smear it on the slide, and let it dry. Once it's dry, examine it under the microscope. If what you've swabbed on is amniotic fluid, you should see ferns that look like, well, ferns, just like on this slide. However, make sure you don't take a sample directly from the cervical os, as cervical mucus, when it dries, can also look like it has ferns. Amniotic fluid ferns are narrower and almost look like crystals, as you see here in this picture, while cervical mucus ferns are wider and thicker. Next is the nitrazine test, which tests for the pH of your collected specimen. Normal vaginal secretions are more acidic than basic, but amniotic fluid has a pH of 7.1 to 7.3, so it should turn the nitrazine paper blue, just like this toilet paper has turned blue. However, it's easy to get a false positive with this one, as many other substances, such as urine, blood, semen, cervical mucus, lubricant, and vaginal infections such as BV and trichomonas, also turn nitrazine paper blue. Good thing we did some other tests too, right? Another study that can be used to support or oppose a diagnosis of rupture of membranes is an amniotic fluid index, or AFI. As you may remember from a previous sketch, the AFI measures the deepest vertical pocket of amniotic fluid in 4 quadrants of the uterus. An AFI between 5 and 24 is normal. Measuring amniotic fluid can come in handy because if the patient's water has truly broken, you should see a lower than normal amount of fluid. Either way, an AFI below 5 warrants further investigation. There are other tests to try to detect various proteins in the swabbed fluid that are present in much higher quantities in amniotic fluid. However, not every hospital uses these tests, and the gold standard still involves visualizing pooling plus positive ferning and nitrazine tests. As we mentioned earlier, you should also make sure that the baby isn't in any distress. This is usually done with a non-stress test. If you need a refresher on what a non-stress test, or NST, is, head on over to our sketch on antenatal testing. Next, you'll want to determine if the patient is currently in labor. While it's never a good idea to do a digital cervical examination on a patient with ruptured membranes due to the infection risk, sometimes you can visually see whether or not the cervix is dilated when you're doing your speculum exam. Finally, you're going to want to rule out infection. We mentioned the labs and info from the physical exam you should have gotten, but let's review them again here. Signs of infection in mom are fever and fundal tenderness. You may also see foul-smelling vaginal discharge on exam. Signs of infection in the fetus manifest as fetal tachycardia. Now let's move on to treatment. If the patient has Pprom, then induction of labor should be recommended. Some centers will allow 12 to 24 hours of expectant management before labor is induced. However, most patients will go into spontaneous labor before this time is up. If the patient is GBS positive, penicillin prophylaxis should be started immediately. Unfortunately, it's not all as easy as Pprom. Treatment and management of preterm Prom depends on many factors: gestational age, whether or not there are signs of infection, if the fetus is showing signs of distress, and a number of other considerations. We're going to go over very general management for 3 blocks of gestational ages: 34 to 37 weeks, 24 to 34 weeks, and below 24 weeks gestational age. For all of these, if mom and baby are showing any signs of a complication, most commonly infection or placental abruption, the answer is deliver. However, if they're not, this is what you should do. If the patient has Pprom and she's between 34 weeks gestational age or more, but less than 37 weeks gestational age, then you'll expectantly manage her unless she's showing signs of an infection or any other complications. This is a new guideline as of 2020. Before, the guideline was to deliver these patients immediately. Expectant management means, well, you let her be and you wait and see what happens. The goal is to prolong the pregnancy as long as possible, ideally to term, without any complications happening. Part of expectant management involves checking regularly for any signs or symptoms of infection, such as fever or fundal tenderness, and monitoring of fetal well-being via NST. You'll also administer steroids for fetal maturity and screen her for GBS. If she's GBS positive, you'll start antibiotics once you believe delivery is going to happen soon. Now, how about if the patient is less than 34 weeks gestational age? If the patient has Pprom and is less than 34 weeks gestational age, but more than 24 weeks, you should also manage her expectantly, plus administer what's known as latency antibiotics. These are antibiotics that are thought to prolong the period of latency, which is the interval between rupture of membranes and delivery. There are many antibiotic regimens that are used, and all should be given for 7 days. A typical regimen used is a combination of IV ampicillin and erythromycin and PO amoxicillin and erythromycin. You'll also want to do what you did for the preterm patients we already talked about. Give steroids for fetal lung maturity if she hasn't gotten them already, and penicillin for a positive GBS test. But another thing you're going to do is give magnesium for fetal neuroprotection if she's less than 32 weeks gestational age. That's why there are 32 makeup tips in this Prom magazine. Now, if the patient has Pprom and is less than 24 weeks gestational age, it gets very tricky, as many of these fetuses will have poor or severely compromised outcomes. You should also manage these pregnancies expectantly and give mom latency antibiotics, symbolized by this thermos in front of the private 24/7 door that looks like an antibiotic pill bottle. However, do not give any steroids, GBS prophylaxis, or magnesium. The most important thing to do for this patient is to offer them extensive time with the NICU and maternal fetal medicine team so that they can understand the nature of this type of pregnancy. Sounds like the limo's here. Let's quickly go over the basics before we finally get to go to prom. All of these patients are going to complain of a gush or leaking of fluid. Once you hear this, you need to rule out Prom or Pprom. You do this by doing a sterile speculum exam to check for pooling. If you see a big pool of water in the vagina, she's probably ruptured. You should also take a swab of the fluid to check to see if there's ferning and if your swab turns the nitrazine paper blue. You can ask her to cough to see if fluid comes out of the cervical os to really prove to yourself that she's ruptured. We started off discussing the big event itself, Prom, also known as term pre-labor rupture of membranes. That's when the amniotic sac ruptures at 37 weeks gestational age or more. Term Prom isn't that big of a deal since the fetus is developed enough to meet the world. It's recommended to induce labor in these patients so that they can deliver. Well, that was simple enough. But then we move to Pprom, which is premature pre-labor rupture of membranes that happens prior to 37 weeks gestational age. The main complication of Pprom is preterm delivery, which can cause complications in the newborn such as respiratory distress, necrotizing enterocolitis, intraventricular hemorrhage, and if the rupture occurs super early, pulmonary hypoplasia and skeletal deformities. The most notable known risk factor for Pprom is infection, usually of the lower genital tract. Treatment for Pprom depends on gestational age. For those between 34 weeks and 37 weeks, the treatment is expectant management plus antenatal steroids if they haven't been previously given. Give her antibiotics if she's GBS positive and you're close to delivery. This is a brand new guideline as of 2020, because before you would deliver these patients immediately. So pretty big change. If the patient is between 24 weeks gestational age and 34 weeks, then you should also manage her expectantly, but add on latency antibiotics to try and prolong how long the fetus stays in utero. Remember magnesium for neuroprotection and steroids if she's eligible, as well as GBS prophylaxis. Finally, we discussed pre-viable Prom, which is rupture prior to 24 weeks gestational age. These patients get expectant management as well as latency antibiotics, but the most important part of their management is a referral to the MFM and NICU teams. Many times, the outcomes of these pregnancies are very complicated, so it's important to get the patient and her family as much support and information as possible. Regardless of the gestational age, if at any point there are signs and symptoms of an infection, such as fever, fundal tenderness, or unresolved fetal tachycardia, you should head to delivery. Other indications for immediate delivery are any prolonged fetal signs of distress or concerns for abruption. And with that, we're finally off to prom.